Hello, dear colleagues. Today we talk about a common pregnancy complication, placental insufficiency. Placental insufficiency leads to fetal growth retardation or fetal growth restriction, is associated with a high risk of parental morbidity, parental mortality. This occurs in many obstetric pathologies, most complications, and extragenital pathologies complicating pregnancy. As usual, as the beginning of the lecture, I'll talk about the definition of placental insufficiency. This definition is quite general, since the etiology and pathogenesis of this complication of pregnancy are completely different and depend on the background pathology, obstetric pathology or extragenital pathology that existed before pregnancy. So, placental insufficiency is non-specific polycausal syndrome characterized by dysfunction of the placenta and manifested by inadequate provision of the process of growth and vital activity of the fetus. First, let's remember the functions of the placenta. We talk about the placenta already in the first or second year of university, when on histology we disassemble the embryonic period of the placenta and talk about more than 10 main functions of the placenta. Main functions of placenta in the first, respiratory, second, transport of nutrients, water, immunoglobulins, endocrine function, human chorionic gonadotropin, placental lactogen, progesterone, estrogens, more than 40 compounds involved in the regulation of the normal course of pregnancy. In the fourth, excretory function, fifth, participation in the contraction of the myometrium, immunological function, and barrier. Further in the lecture, I will tell you what is the clinical manifestation of that functions of the placenta. The presence of such a complication as placental insufficiency occurs with a large number of obstetric complications. In miscarriage, placental insufficiency we observe in 77% of cases. In 60% of all preterm birth may be placental insufficiency, with preeclampsia, eclampsia 70%, with extragenital pathology such as diabetes mellitus, arterial hypertension, endocrine disease, obesity, disease of the thyroid gland, maybe 45%, in acute and chronic infection 60%, with hormonal disease even before pregnancy, if a woman has hormonal disorders, in 21% of cases. It's very important to talk about the relevance of placental insufficiency. Later in the lecture, I'll talk about difference between fetal growth restriction and small for gestational age. Suboptimal fetal growth is important, as a ASGA baby comprise 28 to 45% of non-amylose stillbirth. ASGA infants recognized before birth who undergo surveillance and timely delivery have a 4 to 5-fold reduction in mortality and severe morbidity. And infants born with small for gestational age have higher rates of neurodevelopmental delay, poor school performance, childhood and adult obesity, as well as metabolic disease. It's very important to say about the influence of unfavorable factors affecting the development of fetus antennatally of its further life after birth. David James Barker was an English physician and epidemiologist and originator of the Baker hypothesis that fetal and early infant conditions have a permanent condition effect on the body's metabolism and chronic condition later in life. This increased susceptibility results from adaptation made by the fetus and environment limited on its supply of nutrients. The thrifty phenotype is a component of the fetal origin hypothesis. These chronic conditions include coronary heart disease, stroke, diabetes mellitus, and arterial hypertension. And we are now talking about this theory because it's not enough to cope with placental insufficiency at the moment. We must think about the prognosis for health and the prognosis for later life. Unfortunately, at the moment in Russia there is no approved protocol regarding the etiology, pathogenesis, diagnosis, tactics, and prognosis in placental insufficiency. As you can see on this slide, there are such guidelines, national guidelines, in the United Kingdom, New Zealand, Canada, Ireland, the United States, and France. There are still no guidelines in the Russian Federation, unfortunately. The next question we need to talk about is the classification of placental insufficiency. Please note that there is no universal classification. Each of the available shows individual aspect of the formation of the pathological process. Currently in Russia, the international classification of disease of the 10th revision is used. Most likely we will switch to the classification of the 11th revision in 22. According to the ICD-10, we can attribute the following conditions to failure: obstetrician. Most obstetricians most often use disease with the cause starting with the letter O, or 36.3 maternal care for signs of fetal hypoxia, 0.4 maternal care for intrauterine death, and 36.5 maternal care for poor fetal growth. There are several types of classification. Firstly, we can talk about classification depending on the initial link or primary link of the pathological process. There are hemodynamic, cellular, parenchymal, and placenta membrane. Placental insufficiency. Hemodynamic placental insufficiency manifested by circulatory disorders in the uterine placenta and fetal placenta basins. Cellular parenchymal associated with the violation of the cellular activity of the trophoblast and placenta. And C, not B, placental membrane, characterized by a decrease of the ability of the parenchymal membrane to transport metabolites. However, I repeat that not in all cases we can identify the initial or primary link of pathogenesis, and most often we are talking about a mixed version of placental insufficiency. Placental insufficiency classification in relation to the timing of the formation of the placenta, primary and secondary. Primary develops up to 16 weeks of gestation during the period of implantation at the early stages of placenta development and embryogenesis under the influence of genetic, endocrine, infections, and environmental factors. Enzymatic insufficiency of residual tissue, anatomical disorders of the structure, location, attachment of the placenta, as well as defect in vascularization and disturbances in chronic maturation play a great role in the development of primary placental insufficiency. Morphological manifestation of implantation abnormalities, umbilical cord anomalies, filamentous sensation of the cord, marginal, and placental anomalies. And secondary placental insufficiency develops against the background of the formed placenta in the second half of pregnancy, after 20 weeks of pregnancy, under the influence of exogenous factor, morphological manifestation with uteroplacental and fetal placental circulation disorders, involutive dystrophic changes in chorionic villi, and cellular tissue compensatory adaptive reactions of the placenta. And note, this classification is very nominal classification and used in Russia and other countries. We use the following classification quite often. According to the clinical cause, placental insufficiency classification, depending on the clinical cause, placental insufficiency can be acute or chronic. Acute develops with a sharp violation of the perfusion of the uteroplacental blood flow. The cause may be placental infarction, may be placental abruption, progressive placental abruption, as shown in this slide. Develops acute violation of decidual perfusion. Chronic placental insufficiency, we often observe chronic placental insufficiency under any pathological conditions such as diabetes mellitus, obesity, anemia of pregnant women, rhesus immunization, as well as in the presence of habits such as smoking. And the chronic definition of chronic placental insufficiency is gradual deterioration of decidual perfusion as a result of decreased adaptation under the influence of pathological condition of the mother. Maybe genital disease, maybe disease before pregnancy, pregestational condition, and maybe obstetrical disease. The following classification is also widespread in Russia. This classification includes different degrees of compensation of placental insufficiency. It's very important to note that this classification doesn't apply abroad in other countries. According to the degree of compensation, placental insufficiency may be compensated, subcompensated, and decompensated placental insufficiency. In the lecture on preeclampsia, we have already talked about great obstetrical syndromes. Great obstetrical syndromes are pregnancy complications associated with placental defect, limited remodeling, and obstructive lesions of the myometrial segment of the spiral arteries. Such manifestation of placental insufficiency as fetal growth restriction, intrauterine fetal death, refer to great obstetrical syndromes. 2. Etiology of placental insufficiency. Key features of great obstetrical syndromes: polyetiological, prolonged clinical stage, frequent fetal involvement, clinical manifestation that are often adaptive in nature, and predisposition to a specific syndrome dependent on the interaction of genes and the involvement and or complex gene-gene interaction of the maternal and fetal genotypes. A histological examination of the placenta is mandatory when we diagnose the presence of placental insufficiency. We see changes in the spiral arteries and changes in the structure of the placenta. You saw this slide in the lecture about preeclampsia. The pathogenesis of preeclampsia and primary placental insufficiency are the same. The cause may be violation of the second wave of cytotrophoblast invasion, with the cause from 7 to 16 weeks of pregnancy. In the normal course of pregnancy, the endothelium, the inner elastic layer, and muscle plates of the section of the spiral arteries are displaced by trophoblast and fibrin-containing amorphous matrix. Preeclampsia and primary placental insufficiency are associated with the absence or incomplete invasion of the trophoblast into the region of the spiral arteries, which leads to preservation of a section of the vascular wall which has a normal structure and is sensitive to vasoactive influences. Subsequently, the effect of these vessels of substance that cause vasospasm leads to the narrowing of the lumen up to 40% of the norm, and the subsequent development of the placenta ischemia. Normally up to 95% of 100, maybe 115 spiral arteries of the uterus are subject to physiological changes, while with preeclampsia and primary placenta insufficiency only 10%, you can see 3 to 10% undergo proper normal modification. Violation of invasion as a result of pathology of trophoblast, genetic factor, and adequacy of the decidual reaction, and pathology of the vascular endothelium of the placenta bed, systemic vascular pathology, diabetes mellitus, autoimmune diseases. Once again, about the importance of histological examination of the placenta, we see changes in the spiral arteries in women with placental insufficiency and with the severe preeclampsia. As a result, we can talk about the etiology of placental insufficiency as a etiological disease, the cause of which can be both disease of the woman and the fetus, and abnormalities of placenta. In addition, endogenous and endogenous factors play an important role depending on which primary or secondary placenta insufficiency develops: woman factors, fetal factors, and placental factors. Maybe mixed influence of etiology of placenta insufficiency. And say the same thing on this slide, plus genetic factors. Now we can move from general causes of placenta insufficiency to specific ones. A larger role of the formation of placenta insufficiency is played by the woman's age, parity, obesity, or underweight, in vitro fertilization, the level of physical activity, and adherence to the different diet. If a woman has a history of childbirth with small for gestational age, maybe intrauterine growth restriction, premature birth, previous pregnancy developed with the preeclampsia and eclampsia, or we observe a small or, on the contrary, a long intergenerative interval, less than 6 months or more than 5 years, 60 months, then we expect a greater likelihood of placental insufficiency. Pathological conditions such as arterial hypertension, diabetes mellitus, kidney disease, antiphospholipid syndrome are also risk factors for the considered complications of pregnancy. We must pay specific attention to the peculiarities of the current pregnancy, repeated threats of miscarriage, the presence of preeclampsia, non-progressive placental abruption, as well as changes in biochemical parameters that are measured in a screening study. Study are risk factor for placenta insufficiency. I showed this slide at the beginning of this lecture, and this is how placenta insufficiency manifests itself depending on the function of the placenta. Respiratory function, signs of fetal hypoxia, increased fetal activity, alternated with a decrease of complex substance, transport nutrients, water, immunoglobulins, fetal growth restriction, endocrine function, fetal growth restriction, fetal hypoxia, prolonged pregnancy, excretory function, oligohydramnios, participation in the contractions of myometrium in labor, uterine contraction abnormalities, or maybe atonic or hypotonic bleeding in early postpartum period, immunological functions, intrauterine infection, rhesus conflict, barrier function, intrauterine infection. The clinical cause of placenta insufficiency is due to the main pathology against which is developed, the intensity, duration, and nature of the impact of damaging factors, development stage of the fetus and placenta, pregnancy term, and the severity of the adaptive and compensatory capabilities of the mother placenta fetus system. Objective manifestation, clinical manifestation, objective clinical manifestation, fetal growth restriction, signs of fetal hypoxia, disorders of the uterine fetal placental blood flow, fetal arrhythmia, violation of the reactivity of the fetal cardiovascular system in cardiotocography, impaired fetal motor activity, and early passage of meconium. Note that early passage of meconium is debatable due to the exciting opinion that meconium in amniotic fluid is not a manifestation of hypoxia but an aggressive environment against which hypoxia can lead to aspiration of meconium, and oligohydramnios. Fetal growth restriction, grade classification is used only in Russia. There are 3 degrees. First degree of weight of the fetus lags behind the normative criteria by 2 weeks of gestation. Second degree for maybe 5 weeks, and third degree for 5-6 weeks or more. Some suggest to consider the 10th, 5th, and 3rd percentile as boundaries respectively. Maybe a classification of fetal growth restriction asymmetric and symmetrical. Asymmetrical reduction of only the size of the abdomen, symmetrical FGR, proportional reduction of the all sizes, forms of the intrauterine growth restriction. Recently, this classification hasn't been recommended by international communities since it doesn't determine tactics and forecast. But in Russia, we use this classification and use this classification in obstetrical diagnosis. We must remember 2 main definitions concerning placenta insufficiency, fetal growth restriction, and small for gestational age, IUGR and ISGA. But if growth retardation is one of the main manifestations of placenta insufficiency, then ISGA is a variant of the norm. Fetal growth restriction, pathological condition in which the fetus cannot reach its genetically programmed growth potential, and high risk of poor outcome for the fetus or newborn. Small for gestational age is a normal condition in which fertometric values are below a certain threshold for gestational age, and most often associated with the constitutional characteristics of the parents. A low risk of adverse outcome for the fetus or newborn. Imagine a couple of a woman who heights 100 kilograms and 180 centimeter tall, and her husband is about the same size. In a normal pregnancy, we expect the birth of the child without growth restriction weighing more than 3,000 grams. But if a woman weighs about 50 kilograms during pregnancy and her height less than 155 centimeters, has a thin, short husband, we should not expect a child of about 3-4 kilograms, and the lack in fetal growth from normal values is many causes for this woman will be her individual norm, and we talk about small for gestational age is normal. Main problem in diagnostic of the placental insufficiency isn't difficult to identify the characteristic clinical symptoms, but the diagnosis is made when therapy and improvement of parental outcomes are practically impossible. Main diagnostic methods in diagnostic of the placenta insufficiency: external static examination, lagging of the uterus from the norm, no increase in the fundal height in the dynamics, cardiotocography, and in the third, ultrasound examination, photometry in dynamics, Doppler blood flow, amniotic fluid index. At each appointment with an obstetrician, starting from 25-27 weeks of pregnancy, the height of the fundus of the uterus and the circumference of the abdomen are measured. There are normative tables by which we can determine the normal increase in the height of the fundus or growth restriction. It's very easy to remember the normal height of the fundus. There is a McDonald's rule that distance measurement in centimeters is approximately equal to the weeks of gestation from about mid-pregnancy until nearly the end of pregnancy. A difference of 2 centimeters or more from the expected values can be observed when incorrect calculation of the gestational age and maybe in placental insufficiency, fetal growth restriction, small for gestational age, oligohydramnios, maybe macrosomia, polyhydramnios, multiple pregnancy, and other causes. Also, at each visit to the doctor, a gravidogram is built, and one can understand the norm of pathology of fetal weight gain. Determination of gestational age from the first day of the last menstrual period, when a woman has a regular cycle, accurate menstruation data. But the data of ovulation or conception, if a woman knows about it, and according to the first extended screening, if the data for calculation of gestational age by the last menstruation and ultrasound for a period of 30 weeks and 6 days diverge by 5 days or more, the gestational age is set by the date of ultrasound rump length. In the absence of the first screening, the second screening ultrasound is taken into account up to 22 weeks biparietal diameter, and fourth by the date of follicle puncture, embryo replanting during in vitro fertilization plus 2 weeks. Determinable gestational age by the date of ultrasound, crown, rump length in first combined screening. The next widespread method for diagnosis of the condition of the fetus in diagnosing placental insufficiency is cardiotocography. Is a technical means of recording the fetal heartbeat and the uterine contraction during pregnancy. Consists of 3 main components: fetal heart rate, ectogram, fetal movement, and uterine activity, contractions of uterus. There are normal indicators of cardiotocography which indicate the normal condition of the fetus. The presence of tachycardia or bradycardia, changes in heart rate variability may indicate of the presence of placental insufficiency and show the degree of its compensation. On this slide, you can see different types of pathological cardiotocograms, talking about subcompensated and decompensated placenta insufficiency. Continuation of previous slide, cardiotocogram with severe disturbances in the reactivity of fetal cardiovascular system with low variability, with a rhythm that's difficult to interpret, eventually fetal death. Terminal CTG. To determine the estimated weight of the fetus, it's very important to conduct an ultrasound examination. It's important to know that ultrasound isn't an accurate test method, but for an approximate determination of the conformity of the size of the fetus to the gestational age is necessary. Estimated fetal rate, biparietal diameter, abdominal circumference, and femolate, and using of Hadlock's or Shepard, mainly Hadlock's formula. The International Fetal and Newborn Growth Consortium for the 21st century, or Intergrowth 21st, is a global multidisciplinary network of more than 200 researchers and clinicians from 27 institutions in 80 countries worldwide. Women with accurate gestational age assessment had ultrasound scans every 5 weeks from 14 weeks until 40 weeks gestation. At each visit, measurement for fetal head circumference, biparietal diameter, occipital frontal diameter, abdominal circumference, and femolate were obtained by dedicated research sonographers using standardized methods and idential ultrasound machines, and constructed reference centers tables. Fetal growth rate, quantitatively normal fetal growth is a singleton pregnancy increase from 5 grams per day at 14-15 weeks of gestation to 10 grams per day at 20 weeks, and 30-35 grams per day at 34 weeks. After 34 weeks, the growth rate of the fetus slows down. So we measured the height of the fundus, performed an ultrasound scan, and determined that the size of the fetus doesn't correspond to the normative tables. However, this doesn't mean the placental insufficiency is present in 100 cases. Look, it has been found the healthy small fetus can be found in 40% of all ultrasound findings. The slide presents a differential diagnosis between fetal growth restriction and small for gestational age. Small for gestational age is normal for woman less than 10 percentile for term without signs of fetal distress, normal uterine placental blood flow, normal cardiotocogram, more than 3 percentile for the term, and weight gain in a dynamic study 10-14 days. Intrauterine growth restriction less than 10th percentile for term with signs of fetal distress, less than 3 percentile for term, and no weight gain in the study over time 10-14 days in 2 weeks. If we are talking about the identified fetal growth restriction, it should be said that there are two types of growth restriction: early onset or late onset. Prevalence only 1%, early onset before 30-34 weeks of pregnancy, severe placental disease, Doppler and abnormal, high association with preeclampsia, in many cases severe hypoxia, high mortality and morbidity. Late fetal growth restriction, prevalence up to 5%, mild placental disease, normal Doppler, normal blood flow in placenta and umbilical arteries, low association with preeclampsia, mild hypoxia, lower mortality but common cause or late stillbirth. Another parameter that will tell us about the possible presence of placenta insufficiency is an ultrasound Doppler study in the uteroplacental blood flow. One of the important parameters is the pulsatility index is calculated from parameter in ultrasound derived from the maximum, minimum, and mean Doppler frequency shifts during a defined cardiac cell cycle. We study blood flow in the umbilical arteries, uterine arteries, middle cerebral artery, and ductus venosus, venous duct. This is a comprehensive table uses which taking into account photometric and Doppler velocimetry, Doppler indicators. We can differentiate between fetal growth restriction and small for gestational age. We will not dwell on this in detail. I said that placenta insufficiency is divided into compensated, subcompensated, and decompensated, and on this slide I show the signs of these of the types of placenta insufficiency. I draw your attention to the fact that the classification is used only in Russia and is very subjective. However, is accepted that chronic placenta insufficiency, compensated or so on, decompensated, subcompensated, included in the obstetrical diagnosis in Russia. Compensated placenta insufficiency, fetal growth restriction of the third degree may be a normal fetal weight, violation of uteroplacental blood flow. Fetal growth restriction of the second degree in subcompensated, violation of fetal placental blood flow, and decompensated fetal growth restriction of the third degree may be severe violations of fetal placental blood flow or antenatal fetal death. And I repeat it, use only in Russia, very subjective. Placenta insufficiency treatment main problem changes in the placenta with primary placenta insufficiency and early intrauterine growth restriction are primarily caused by thrombosis of the vessels of the villi and chronic villi with subsequent ischemia, fibrin deposition of the development and of infarction, which leads to impaired placental perfusion and the interaction of the trophoblast with the uterine vessels of the placental bed. This makes the vessels insensitive to most drugs. When we talked with you about preeclampsia, we said that the only effective treatment for preeclampsia is delivery, termination of pregnancy. Is delivery the only one effective norm for placenta insufficiency too? Maybe, because main problem, late detection, delay in treatment, practical impossibility of improving fetal placental blood flow, and there is no defect of antenatal measures to improve the conditions of the fetals. A meeting of the European Association of Obstetricians and Gynecologists. Placenta insufficiency treatment, quitting of smoking at any stage of pregnancy, elimination of the etiological factor, pathogenetically substantiated treatment of pregnancy complications, and genetically substantiated treatment of complications of genital disease. Magnesium sulfate up to 34 weeks for fetal neuroprotections. Dexamethasone course 24 milligrams 3 times 8 grams intramuscular for prevention of respiratory distress syndrome of the fetus, and no effect of vitamins, progesterone preparations, beta mimetics, dipiridamole, hyperbaric oxygenation, oxygen cocktails, and diet changes. The use of low molecular weight heparins in high-risk pregnant women leads to a decrease in the risk of perinatal mortality, premature birth, and the birth of children with growth restriction. And diagnostic search for suspected small for gestational age and or intrauterine growth restriction. Suspected this conditions, medical history, confirmation of gestational age, and ultrasound. Biometry appropriate for gestational age, yes. Exclusion, small for gestational age or intrauterine growth restriction, no. SGA. Amniotic fluid volume, oligohydramnios, no. Is normal, yes. Maybe SGA, maybe FGR. And Doppler ultrasound, uterine umbilical arteries, abnormal, no is normal, yes, maybe small for gestational age, no, but maybe fetal growth restriction. Detailed ultrasound anomaly scan and the diagnostic genetic workup, maybe diagnostic infection workup, touch infection, and maybe we find different cause of placenta insufficiency, placental cause, fetal and maternal cause. In tactics for intrauterine growth restriction, diagnosis intrauterine growth restriction, Doppler sonography, if normal, control scan every 2 weeks till gestational age 38-39 weeks, Doppler sonography, pulsatory index more than 95th percentile control scan at least every week till 37 weeks. Doppler sonography with absent and diastolic flow control scan daily or every few days till 34 weeks, and reversed and diastolic flow control scan daily or every few days till 32 weeks of pregnancy. Delivery in perinatal center with the neonatal intensive care unit, possibly administration of antenatal corticosteroid dexamethasone 24 gram, possibly administration of magnesium sulfate for neuroprotection. Doppler sonography of the middle cerebral artery, Doppler sonography of the ductus venosus, and CTG analysis with criteria by doses Redman. And prediction of placenta insufficiency, anamnesis, ultrasound examination at the beginning of the second trimester, increased pulsatory index of the uterine artery, small placenta volume, decreased resistance index in the middle cerebral artery, and low PAP level. In the future, pro and anti-aging factors may be placental growth factor, vascular endothelium, growth factor, and soluble ferments like tyrosine kinase 1. This concludes our lecture. Thank you very much for your attention, and goodbye.